So thank you too much for an invitation for me in your hospital and that conference. So, and our experience of the treatment of club feed in Elizarov method, as everybody know, is very great. Yeah, and but we know, everybody knows that complication after treatment of club food in youngest childhood practice sometimes can be in highest period. In that group, patients can be from 30 to 50% of complications. So, and in our research, we include 65 patients with 77 foot, with middle age 15 years old. 8 patients who was treated because before us, but unsuccessful, and that patients can take complications in a recurrence of club foot deformity. Yeah, all that patients we crushed on 2 groups with shortening feet and with normal feet. In normal feet, without shortening, we see two groups patients. In second degree by Demeglio, it is 24 feet, 80 patients, and in that group we was made one surgery with simple correction of deformity, acute correction of deformity, and triple arthrodesis with Achilles lengthening and tenotomy of flexors of the toes. And in the third and fourth groups is very severe deformity. We find 23 feet. And in that group, our treatment was consist from 2 stages. In first stage, we was done Achilles tendon lengthening with tenotomy of flexor of toes, and Elizarov external fixator for gradual correction in postoperative period. And after correction, we was made second stage, triple arthrodesis. So in second group with shortening feet, we find second degree by Demeglio score 16 children, and in that group for correction of deformity and one moment for lengthening of the feet, we was made Achilles tendon lengthening with tenotomy of flexors of the toes and osteotomy in midfoot and calcaneum bone for lengthening, and of course Elizarov fixator. And for very severe deformities, third and fourth degrees by Demeglio with shortening, we find 14 patients. And in treatment of that group was done by 2 stages. And when in first stage we was made acute correction of deformity with triple arthrodesis, and in second stage we done midfoot and calcaneum bone osteotomies for lengthening and full correction of the deformity. So, and After treatment, after removal of device, all patients was working with physiotherapist and was fixed in orthotic from 6 to 12 months. And next, some examples from our experience. So, male patient, 15 years old, with club foot, demeglio second, with two sides deformities, and he was treated in our department. In first stage, we was treated left foot, was done correction of deformity with triple arthrodesis, and after 2 months, was treated right foot and was done same triple arthrodesis with acute correction, and in final patient we was take a good result. So another one, male patient with club foot, severe deformity, and we was treated him by 2 stages, and in first we start work with left foot. So, and in first surgery we was done little bit by 1 moment correction with Elizarov fixator, with Achilles tendon lengthening, and with tendon of the fingers lengthening. And after surgery, gradually full correction, and in second stage was done debridement, or was done triple arthrodesis. And similar, we was made in next step after 3 months. After 3 months from first surgery on the left foot, we was treated right foot, and in final we was take a good result. Another one case, male patient, 71 years old, very severe deformity of the left foot, and we was treated him by 2 stages. In first stage, we was done full correction with tendon lengthening, with tendon plastic, with Elizarov fixator, and in the next stage was done triple arthrodesis, and in final, patient can walk without deformity. So, and another one case with shortening 5 centimeters, with club foot, and in that case, we was done tendon lengthening and osteotomy in midfoot and calcaneum foot and calcaneum bones, and in postoperative period, gradually it was done full correction of deformity, and summary time of fixation in the Elizarov device was 3 months, and patient have a good result, can walk and don't have deformity. So another one, female patient, 16 years old, with shortening 3 centimeters. We was done lengthening of she's feet and deformity correction of she's feet, like in previous case. So, summary duration of correction was in groups without lengthening. In maximum time was 58 days in very severe group, and in similar very severe group, in group with lengthening, total time of mid-time of duration was 81 days. And time of fixation period in group without lengthening was 1.5 months, and in group with lengthening, 2.5 months. So, and the result by our FAS, as you can see, most patients have a good function after our treatment, but in 5 cases with very severe disorders, neurological disorders, we take not bad, but and not good results. Yeah. So, and what about complications? In certain patients, we find some complications like soft tissue inflammation around the wires, cutting of soft tissues by wires, premature consolidation, cutting of bone by wire, and osteophytes on plantar surface in one case. All complications we was treated in the next stage of treatment, and summary is that patients have a good result, and finally. So, and I should repeat that very important fixation of the toys by wires intermedullary. It is important for prevention of flexible in toys joints. And about ischemia, it's too important, especially in acute correction. After removal tourniquet, if we see symptoms of ischemia, of course we create little bit deformity again, and in postoperative period, gradually we correct it in normal position of foot. So, compliance with the methodical principles of transosseous osteosynthesis by Elizarov in surgical treatment of patients of school age with recurrent congenital clubfoot, and rational management of patients in a postoperative period is prevention of complications and contributes to achieving a good results. Thank you for attention.
Thank you so much, Anatoly. We're going to open up the floor for discussion for these two gentlemen. Dr. Herzenberg.
Anatoly and Milan, those are great talks. And I'd just like to say that you're showing us these wonderful frame cases, good results. And about 15, 20 years ago, I started doing this as well. And then along came the Ponseti method, and some of my fellows who are practicing in the developing world, like Monica Nogueira in Brazil, started doing the same treatment and getting very similar results with casting, like what we saw in the earlier presentation. So my question to you, you've shown us these beautiful cases from India, from Russia. Is this what you're doing now, or are you starting with casting first, and are you getting good results with casting, or you're not getting good results with casting? So I'd like to direct that same question to Anatoly and to Milan.
What about our experience, and what about my opinion about that? So I think that in youngest patients, for example, not more than 5 or 6 years, we should first to do Ponseti method, I think. And it is because in that time, in that period, children don't have very severe deformities. That usually the deformities can correct by one moment, sometimes without some special operatively interventions. And what about others? I mean, patients from 6 years and oldest. I think here as we should look their deformities. If we see severe and very severe deformity, of course it is Elizarov technique. And if not severe, if we think that we can correct it without some external fixators. Of course, we should to do Ponsati method. It's my opinion. So, and in our center now we do same like I told you. Sometimes we used for fixation of the feet intramedullary nails for a short time. Yeah.
This is a really interesting question. And I came up with the kinesiological method in 2002, but it seemed to me over the years I've kind of orphaned my offspring in that sense, because I don't do it in each and every case. And most of the children and most of the young adults who have a pristine foot, who have not had a soft tissue release, or don't have a very obvious fibrotic hind foot, or the ones who have had a posterior-medial soft tissue release have this splaying of the, what I heard yesterday, the most appropriate term, wicked soft tissue contractures. If they don't have that, then I'll definitely start with casting. And I showed results in even up to 22. But if they have had previous soft tissue surgeries and the feet are really stiff, you flex the knee and there's no movement in the ankle and nothing's going to, you know that the casting is going to take forever. Because if you start with casting in older children, it can work, but each cast has to remain on the foot for 3 to 4 weeks. And sometimes you need 6, 7, 8, 9, 10 casts. And there can be a hindfoot stall in the older Ponsati treatments. So you get a judgment call on that and start with the fixator. So I don't do it in every case. I think half the people get the frames.
I just would ask you, why do you think you have to leave a cast on an older child for 4 to 6 weeks, or even 2 weeks? I think you can change them just as rapidly. Monica, I think, made me really look at this carefully. I mean, she presented a 28-year-old that she almost exclusively casted, and it was not months and months of casting. It was pretty quick. And I think we talked about in the first discussion about preparing the soft tissues with casting, because I mean, I put a lot of frames on for these complicated feet, but I am still surprised at how much correction I can get with some casting. And you know, maybe you do have to put some on, but I would argue that 6 is not a cutoff for me. 28 is not, I mean, well, 18 is a cutoff, unfortunately, at a children's hospital for me, but I really do work very hard on those soft tissues, because after you take off that frame, I mean, the reality is you've got a relatively stiff foot. So I don't know, I wouldn't throw out casting.
Yeah, your point is taken. I was getting longer casting times in the feet that were rather stiff. So if we choose our feet for casting or for the frames, then carefully, then we'll have lesser duration in the cast.
Charlie,
Yeah.
you're up.
Congratulations again to both of you for showing us these incredible cases, but I have to ask you or challenge you to show us the patients walking, because many of your x-rays, many of the appearance is that the foot is still really in equinus because they have no dorsiflexion due to the misshapen and dysmorphic talus. There's no recess on the top of the talar neck, and this is a result of the neglect and the dysmorphic features. So if a patient has no dorsiflexion during stance, they are going to develop pain in the calf, recurvatum at the knee. And so I would ask you, after doing these extensive and very talented corrections, how are the patients actually walking, and how do they function, especially once they've been able to reassume normal weight bearing, or as normal as possible?
Thank you for a very relevant question. Like one of my great teachers always said, nothing shatters confidence like follow-up. So it's a fact. They come with very bad feet in the first place. Many of them are developing very bad callosities on the dorsum, and they're really walking horribly. They're limping horribly. And your very astute observation that we are not making these feet pristine, the really bad ones. And they can have recurrence of deformities. They may go through a brief honeymoon phase where everything is fine, but over a period of time, they're going to lose some movement in whatever the ankle movement was remaining. Some of them will have a recurrence of the deformity. Some will need a tibialis anterior tendon transfer. Some will need a triple arthrodesis at a later stage. And the really bad ones, perhaps even an ankle fusion.
How often are you doing your supramalleolar dorsiflexion osteotomy to bring the foot up again a little bit more outside of the foot?
Now that you ask, probably I should be doing them more often.
Can I ask, Tony, you do a lot of triple fusions in your correction, and the corrections are fantastic, congratulations. But how do you manage the ankle problems down the line? So in my experience, if you do a lot of triple fusions in the teenage population, that when they run into trouble with their ankle, the management of that in adult life is very difficult.
So, for protection of ankle joint, usually every times we do for protection of ankle joint, we put in talus bone 1 or 2 wires. In different cases, different, yeah, and we do gradually little bit distraction of this joint for protection, for its protection, and as you can see in slides, that medium time of fixation in Elizarov device summary from start of treatment and to removal device in simple group, in first group, 2 months, not more. And for that time, it is nothing will do with ankle joint, I think. And in our experience, in my experience, we don't see troubles with that joint after treatment. And what about in what about groups with severe and very severe deformities and some, if that patients have some troubles of ankle joint, so we can do better nothing better for that joint, and we don't do some bad for the joint. We can stay the joint in same condition like before treatment.
And do you follow them long term?
Yes, we have long-term results.
Thank you.
Wonderful lecture. Going to I know we didn't talk about this, the neurological or arthrogrypotic clubfoot, when they come in, I found that they're the most difficult people to cast out. At what time do you say abort the casting and go to an open release? And what are the degrees of abduction would you want to obtain prior to starting the casting process?
Yeah, over a period of time, the threshold for going in for soft tissue release has reduced. I don't persist with casting. It becomes pretty obvious by, there's frequently even a 4-foot stall, not just the hindfoot stall. So we do advise them, we wait until 6 months at least to prevent the excessive fibrosis, and just let them be for a while, and definitely start with a soft tissue release.
Any other questions? I have one question for Dr. Chowdhury. I've always been very nervous when doing my V osteotomies of making the distal limb of that osteotomy through the talar neck. And I think it's a philosophical fear of mine. There's not a lot of surrounding soft tissues. There's very thin periosteum. And even though it's much closer to the core and it's where you should be making your osteotomy, I've always, I think out of nervousness, made my osteotomies a little distal through the navicular or even through the kind of cuneiform cuboid articulations. Have you had any issues with healing, regenerate formation, need to keep the frame on longer to protect that part of your osteotomy after you obtain correction?
Yeah, that's probably Anatoly can also help us. But I think because we also have a very good hindfoot osteotomy, the whole thing has got a lot of vascularity. So the worries that we have about avascular necrosis of the talus or poor regenerate, not seen so far, not that I've done a huge number of these, but as a matter of fact, we've had premature consolidations because we've not had the construct with the olive wires pulling the forefoot properly. So probably in the reverse direction. The problem is more of premature consolidations in these feet. And that's, I wanted to comment and ask Anatoly, they have really low fixation durations. That's fantastic. And we are certainly not, I'm certainly not getting anywhere as less duration of fixation as they are in Kurgan.
Two or 3 months duration of fixation, and I think it is normal. Yeah.
That's great. Well, Dr. Sakashian. Yeah.
This is actually for both of you, but mostly for Melinda, because you showed impressive, sequence of pansetti with the frame. I mean, you look at this and it's kind of it's simple. But my question is, who is actually doing the changes in frame? Is it you or do you have some help? How long can it take for you to spend the time with the patient when you need to reposition the hinges or readjust the rods so they become tangential? So what's your clinic time there? Do you have a help? Someone doing it for you? You doing it?
So it's like the Beatles song. You get by with a little help from your friends, and of course it's all teamwork. It's all teamwork. You can't do the Elizarov by yourself. And I have trained a lot of technicians, what you call PAs, and I have fellows, and I used to do it all myself in the very beginning, but now I'm very lucky. I can just give them directions. This is how I need the hindfoot motors, especially in the equinus correction. You need to change the montage because after you achieve some correction, then you need to take them a little more posteriorly to remain perpendicular to the moment arm. And changes in the office, as you rightly pointed out, are time consuming. And even shifting the talus wire fixation from as a dropped wire to the calcaneum ring, or changing from the supination construct to the forefoot abduction construct, these can take half an hour or more than that. And a trained team, fellows, residents, is very helpful and useful. You can't live without.
Usually, in our center, all surgeons who work with foot and ankle surgery, everybody knows how to do it and everybody can do it. What about me? All foot surgeries usually I do myself, and V-shape osteotomy and others osteotomy, for me it is not problem. I do it. Yes, I have examples. I have results. Yeah, it's not problem.
Thank you. Those were fantastic presentations. My question is just about closed distraction. I've been visiting a friend in Nepal where they have a huge incidence of clubfoot, and some of these patients are in their 20s. And I was amazed to see the corrections that they were achieving with no osteotomy, just with a gradual Elizarov correction, a purely soft tissue correction, and incredible results. So I've tried that with Hexapod and done that, but my patients are in the frame quite a long time, 6 months, and they have relapsed a little bit, but they're walking much better. But the beauty is that there's no rush with the regenerates. You can go as fast or as slow as the soft tissues allow you.
Yeah, it's like could be like soft tissue regeneration as well. So that's why I also find it takes sometimes much longer in the older ones.
All right, we're going to wrap it up. Oh, we got one more question. Dr. Sanchikov.
Question about the wires through the digits. So, I know our experience, but he doesn't like 100% of his cases. He put 5 wires through the toes. Other people never do that. Some people do this in some cases, some not cases. Do you have like specific indications when you put them in, or you just do this prophylactically for every patient?
We do it especially for severe and very severe deformities for prevention of some hammer deformity of the toes. Yeah, and usually we do in every cases. Yeah, but after correction, after full correction, it can be 2 weeks after surgery or 1 month after surgery, we remove that wires. That wires don't stay full time of fixation in the Elizarov fixator. Yeah. And after removal of that wires, after 2 weeks or 1 month, we start to work with toys like physiotherapy, therapy. Yeah.
Have you taken them to surgery to remove, or you do it in cleaning?
In cleaning, of course, yeah.
One last question here, and we're going to wrap it up.
I like this one. Yeah, actually, this is the first time. It's a good technique. According to the wires through the pins, I'm doing it also. I have 2 different ways to do it. But in cases where you don't have so much lengthening on the flexor tendons, I use simple leather bands in combination with rubber bands. Yeah, and in cases where I have a lot of lengthening in the lower leg or in the foot or correction of the foot deformity, I like to use the wires, but I'm using them much longer than you said, 2 to 4 weeks. This is not enough, yeah, because the tendon takes a long time to adapt to the tension and to the correction. And even if you have it for 3 months, 4 months, I have cases where I leave the wire 6 months. You have a stiffness of the joints, but they all recover. Yeah? And it's more important to prevent crotos with the wires than to have a little bit stiffness of the tendons. The digits recover quite good.
Thank you, gentlemen, so much. It was an excellent discussion.